I said, thank you very much for inviting me. I'm happy to be part of your very nice and successful meeting. I've been in Moldova a few years ago, 4 or 5 years ago, and was very pleased. In my position as Honorary Secretary of European Pain Federation, I'm here to give our greetings and to share our happiness that you are part of us and uh, success to your meeting. I'll one of my
can you put your slides all screen?
Can you see it? I put it.
No, we see it, but smaller, not full screen.
It's full screen. I'll put it again. Why? I don't know why. And now, can you see my slide?
Yeah.
Yes, we can see them, but we can see another part, small one in the right part.
That's what I'm sharing my.
I see all the screen actually.
Okay, you can go, I think.
Let me know if something technical is not working well. So I'm leading the Pain Institute at Tel Aviv Medical Center. We have quite a big pain facility. We are seeing every day around. We're ambulatory medical facility. We have around 100 patients every day, working from 8 o'clock and 7 o'clock in the evening. And I developed in my clinic, in our institute, a special unit for chronic pain patients, having a devoted doctor and few other staff to take care of this special population of patients. So today I'll go over the pain definition in general, prevalence and epidemiology of cancer pain, a new, let's say, topic of changing etiology in cancer pain patient, and a special topic that I'm taking care, and I think that is very important for us to treat cancer pain and altogether in cancer survivors. So regarding pain, we are looking at two aspects: a sensory discriminative. If you hear the previous talk about chronic primary or secondary pain, but I'm looking in let's say another sort of other direction. Is a pain can be sensory or discriminative, let's say where and how much, and affective and cognitive, in terms of unpleasant and appraisal. So at the end of the day is the pain perception of the patient, how our patient is perceiving this bad influx. So is bothering him or her, is not bothering him, is affecting her life or no. This is at the end of the process what's bad for our process, because there are patients who are moving around and are can live with their pain, with big amount of pain, and there are patients with something very small, a small low back pain affect him and putting him in bed for 1 month. So this is the bottom line of what I'm saying: the pain perception and the pain attitude of the patients. Looking in terms of physiology,
I'm very sorry for bothering you, but can you just stop sharing and share again?
Yes.
Your slides are not moving, please.
Okay. Now you can see me, and I'll share again. How is now?
It's very good. Thank you.
Good.
Okay. In terms of physiology, we are looking at a process that started at the level of the skin: transduction, conduction, transmission, spinal dorsal cord, and the end of the process is again perception, experience, and modulation. Sometimes who is experienced with pain can take and can bear a bigger amount of pain that someone else who is just at the beginning, let's say, of the process. In cancer pain patients, is even more complicated and more difficult to understand, because pain seems to be for most of them worseness of the cancer or cancer disease. So it doesn't really mean it's only pain, it's all the process all together. So cancer pain is a mixed mechanism of pain presenting as a pure neuropathic, visceral, or somatic pain syndrome, and rather it may involve inflammatory, neuropathic, ischemic, and compressive mechanism at multiple sites. So to make it simple, it's not only inflammatory, neuropathic, or ischemic, it's for most of the patients is altogether, it's not a very clear and pure pain syndrome. I'll share with you two ideas how can we explain the cancer pain. One is called the total pain theory, that take in consideration all the aspects. This means that it's physical, psychological, social, and even spiritual, and put together the comorbid causes caused by the treatment and cancer, the anxiety, the psychological, they are depressed and anxious, fear of suffering, taking in evidence past experience of illness and past experience of cancer. Social, they are losing their job, they are starting to be lonely. They have financial concerns, worry about future of the family, and for some of the patient, dependence of benzodiazepine or opioids, and spiritual. There are many patients that this is a very important way to fight with disease. Part of our anger of faith, because they are sick, because they are losing their family and their job, are part of the patients are trying to find the meaning of faith, and at the end of the day, the fear of unknown. The other way to look at the pain is the loser pain model, that is pushing four stages: nociception, pain, suffering, and pain behavior. Not all the pain patients are suffering, but all the pain they are suffering have pain. This, you need to understand this, because a patient with pain that can compete and can take care of himself is not all the time suffering. This is very important to know in our mind. The quality of life is a very important issue in this meaning of fight the disease. And as I said, the pain perception and pain behavior, the cognitive behavioral component, are very important in the way that you can help our patients, even without drug or procedure. Just talking with them and help them to increase their trust. They can go over the disease, and they to understand the disease. So regarding numbers, prevalence of cancer pain, around 50% of the patients have pain at the time of the diagnosis of cancer, varying between 20 to 75. Up to 60% of the patients receiving active treatment means can be chemotherapy, surgery, radiotherapy, have pain during their treatment. And at the end of the day, up to 100 of the patients have pain at the terminal phases of their illness. And it's very important to know, as I said, I'll focus on this specific issue of cancer survivors. Around 30 to 40% of cancer pain survivors have chronic pain. So, as I said, most of the cancer that provoke more pain are urogenital, lung, and head and neck. And as I said, during the curative treatment, 30% of the patients have pain, and in all the stages, around 50% of the patients. So there are very big numbers. Taking consideration the big number of cancer pain patients, we are looking of around 50% of the patients that are already presenting with pain at the time of diagnosis, and part of them are getting worse during the treatment and during the last stages of their life. As I said, to sum it up, the numbers, we need to understand that up to 50% of the cancer have pain at time of diagnosis. 2/3 of the patients with advanced cancer suffer from moderate to severe pain, and exist around 5 to up to 10% of the patients that have pain unrelated to cancer. They have back pain, they have osteoporosis, osteoarthritis, so it doesn't matter the name of the pain. It is not related to cancer disease, but influence the magnitude of the pain by this disease. From where the pain is coming, first of all, is related to tumor involvement. Up to 80% of pain problems in inpatients, cancers population, 60% of outpatients population is related to tumor involvement. Of course, metastatic bone disease, hollow viscous involvement, and nerve compression or infiltration are most common causes. Minimum 20 or 25% of the cancer population are suffering from cancer therapy, chemotherapy, radiotherapy, invasive surgery. As I said, 5 to up to 10% have pain unrelated to not related to cancer, and a very important and very humanitarian type of pain is generalized pain in a dying cancer patient in the end stage of the disease. Talking a very didactic, we are making the 4 types of cancer pain: somatic, visceral, neuropathic, and headache and facial pain. But as I said, most of the cancer pain patients are suffering from a mixture of disease, like say visceral neuropathic or somatic and neuropathic. Most of them have a neuropathic component of the pain. This is an example of somatic cancer pain, vertebral metastasis, but again, compressing a nerve will have a neuropathic component. Visceral cancer pain, all the cancer is in abdominal cavity. Neuropathic cancer pain, I'll talk more or less. This means that any kind of nerve is involved in a tumor, or in a paraneoplastic disease, or affected by treatments like chemotherapy. Neuropathic pain can be due to tumor-related, directly compression of the nerve, changes in neuronal milieu due to tumor growth, inflammatory response, but also related to treatment, chemotherapy-related neurotherapy, radiation-induced fibrosis during injury of peripheral nerve, and of course, lots of cases of post-surgical post-surgical neuropathic pain after mastectomy or tumor resection that involve nerve. Neuropathic can, as I said, is the issue of chemotherapy-induced pain. I'll talk further in my talk. Is a very important and very difficult to treat pain syndrome. Other issues of neuropathic pain are brachial plexopathy, lumbar plexopathy due to metastasis or tumor in lumbar spine, epidural spinal cord compression, sciatic neuropathy, and many other issues when the nerve is directly involved or indirectly by toxins like chemotherapy or tumor growth involvement. How are we facing? I think in 2009, Breivik and his collaborator published this study showing the prevalence of cancer pain in different European countries. You see the medium response was 70%. So around 70% of the country are reporting that their cancer pain patients are suffering from moderate to severe neuropathic pain. It's going from 43 in Sweden to 95 in Italy, 88 in Israel, also very high number. and you can see the figure in all the countries. The figures are bad, even you can say very bad. So we need to understand that we are not doing that well. We have enough drugs, enough knowledge, but putting together all the logistics and treating the patients is not the best issue that you can do. Probably there is now no other study that show up in the last years. We are, I hope, I don't know, I hope that we are doing better than in the figure in this study that show very bad treatment of cancer pain patients. Another very difficult to treat issue, as I said, is the bone metastasis is more frequent in men, 60%, than in women, 40%. And these are the number of metastases in a few hundred patients. It's a very old study, but quite actual, showing that in the old patient, around 50, 60 men, the presence of bone metastasis is high or very high and difficult to treat, and provoking also fracture and more than the bone pain. As I said, the issue of changing, what I'm calling changing pathology in cancer pain. I think less pain is related directly to carcinogenesis, 69, more to 60 than to 90. Cancer-associated pain indirectly linked to the patient care. We know that this patient care can suffer from low back pain, post-herpetic neuralgia, and many other issues that are related to or not related to the pain. Therapy-related pain and cancer-independent independent pain. You need to understand that even with patients who survive the cancer, any kind of pain is bettering that something wrong is going back. And besides the issue of pain is the issues of anxiety and depression that come together we need to reassess and this patient very fast in order also to treat the pain and the disease. Second, to see there is not a recurrence of the cancer, and also to treat the anxiety of their patient, that everything that is not normal of them is again they are linking to their old cancer disease. Very graphical model of pain in cancer, and then they can putting together more or less my old talk regarding the how the pain is coming. Is, let's say, this is diagnosis, and there is no usually a very clear line. Is coming with good person, it's called remission, or part of them are CARD and are becoming survivors, and the issue of chronic pain in survivor patients. And we are aiming to elevate pain and restore functionality and quality of life in these patients. There are lots of procedural surgical due to the cancer pain due to metastatic disease, pain of the end of the life when things are going bad. And in this patient, we need to reassess to treat the suffering and to improve comfort and what remains of their life at the end of the process. This is summing up all the things that I spoke till now. So regarding numbers, cancer pain experienced by 55 or half of the patient undergoing treatment for cancer. 66% of patients who have advanced metastasis of terminal cancer. I believe from my practice that around 60 to 70% of these patients, we can treat patients quite well with not very complicated resources. But we have at the end of this around 30% of the patients, we can't treat them, we can't help them, and we need to go to very complicated or invasive treatments in order to help them. Another issue that is very important to talk when we are talking about cancer pain is the breakthrough pain. Usually we can treat well or very well the background pain, but it's very difficult to treat the breakthrough pain. And the breakthrough pain impact is very important because it's increasing the anxiety, depression, is putting the patients away from try to work. So there are healthcare costs. They are what kinesophobia. They are not willing. Don't want to go because they are afraid that the pain will come back. So you need to understand that is another issue that more difficult to treat the breakthrough pain because it's short, very important, but with long consequences. So take all the time in your mind that we have two kind of phases: the breakthrough pain and the basic base of the pain. They are not the same treatments. They are quite different other drugs, and we need to treat them in another way. Is around 60% of the patients with cancer pain suffer from breakthrough cancer pain. Is very affecting their willing to work, to be mobile, and to be part of the family. One of the last issues that I want to talk is the what means cancer pain survival. Understanding survivorship, it means that this patient have passed all the stages of the cancer and survived. So they have no sign of cancer after finishing the treatment. They are living with, through, and beyond the cancer, and the point of beyond the cancer. They have a clear diagnosis of cancer. They've been treated and received treatment over a long period of time. There are three phases of survivorship: acute, very just at the beginning of their stage of survival. Extended survivorship starts at the end of initial treatment and goes through month after the end of the treatment. And permanent survivorship is years have passed since cancer treatment ended. There is less of a chance that the cancer may come back. Let's say 5 years more than they finish their active treatment. They are in follow-up, and nothing bad is coming in their life. One good issue is that we are treating quite well the cancer, and the number of cancer survivors are increasingly very, very much. You can see the numbers in the United States. In early 70s, they've been around, the number is around 4, and now we are around 16. So 4 times more survivors than in 40, more or less 40 years. Is quite important and quite good for us that we know to give very good treatment for cancer patients. We are improving our medical knowledge and treating these patients much better. As I said, there is no issue that starts up in the last decade. Pain and cancer survival, a cognitive effective model of system present under certain treatment of disease recurrence. All these patients, they'll have in their back of mind that the disease may come back. There is no way to take this away from their mind. And this is a message that you can reassess the patients and treat them and help them. And part of them, they do have pain, and even important pain. I put here a few articles that I think that are more important to know. A very, very important issue, maybe in the United States, less in Europe, for this kind of patient is addiction. Many of them have been heavily treated of opioids. Is a very good drug for certain period of time, but they became addicted, and they are still going with opioids in this survival period without having very bad pain. So there are very few evidence-based cancer pain guidelines in this population. We don't really know how to treat them. There is quite a new issue. Besides, opioids are the cornerstone of acute and pain or advanced disease, but not in survivors. We are trying now. We are facing quite I don't want to say epidemic of addiction in this specific population. Therefore, higher need for multimodal pain and a plane of care of balancing pharmacological and non-pharmacological techniques. And usually we need to have an interdisciplinary team. And the goal is to improve function and limit adverse treatment, and start trying as much as possible to give more non-pharmacological help than pharmacological help in these patients. Another very nice article showing how to screen, treat, and assessment and mitigation and universal precaution in this population of American Society of Clinical Oncology. So, trying to sum up what I said. These are the most frequent chronic pain syndrome in cancer pain patients, starting from chemotherapy, body complication, vascular necrosis, hormonal therapy-related pain syndromes. You have lots of sexual disparities and myalgia, osteotopic comparative fracture, radiation-related pain syndrome, all together. In patients who have stem cell transplantation, arthralgia, dysuria, eye pain, paresthesia, sclerodermia, like skin changes, surgical pain syndrome, like after breast cancer, lymphedema, post-amputation, phantom pain, post-mastectomy, after radical neck dissection, neuropathic, severe neuropathic pain. And as I said, the last thing that I'm talking about is chemotherapy-induced pain, very severe, very difficult to treat, and usually is going over years and years and years without very good results. Is a direct effect of the nerve of the chemotherapy agents. Some extra things, because I think that treatment should be broadly talking in maybe another talk or another way, and because it's a very long story to treat cancer pain, starting from very simple drugs, going to neuropathic drugs, opioid and procedure, and put all together, putting in the multidisciplinary approach, giving the psychological assessment and support that the patient needs. I want to say few drugs that we are not really, they are very old, usually quite cheap, and we start to use them again. Methadone and ketamine. Methadone was been elaborated during the Second World War, so it's not a new drug. Ketamine, the same. There are very good drugs for acute and neuropathic pain cancer, and are not that used that much that I think that should be used. There are not very simple drugs, but again, the results are quite good. Interventional pain treatments. Since in my institute, Pain Institute, we have usually a referral from difficult pain patients. We are doing this kind of procedure, even destructive procedure like radiofrequency or cryodenervation, less alcohol and phenol in the last decades, but we are moving to new treatments, and we are working together with neurosurgical department, having using very destructive patients like chordotomy in this kind of end of the life patients. We do use neuromodulation for the patients who have a long period of life, the good prognosis, or are cured, spinal peripheral nerve modulation. And as I said, neurosurgical treatment for intrathecal pain should be taken in consideration for these patients when their prognosis is bad or the pain is so difficult to treat that we are behind any kind of treatments. We do use also intrathecal morphine pumps for these patients. And I need to say that a very important issue is to have a palliative service that know better than not only palliation but only pain, is working together with the pain services and can collaborate together with all these issues together: pain, palliation, neurosurgery, and having the psychology issues together. So to sum up my talk, the good news is there is increase of cancer survival rate. The bad news, increase in chronic pain in cancer survivors. We are not doing that well, as I said in the last survey. Hopefully, we will improve in all. Is not only in one country, is all over the Europe. The opioid epidemic and addiction problems occur also in survivors. There is a high need for improvement for non-pharmacological approaches to treat chronic pain in cancer survivors. There is the issue not one size fits all approaches. We need to tailor the treatment for every patient, because everyone has his own disease and own background, and we don't usually succeed to treat one patient with all the patients with one measure. We need more drugs and approaches for chemotherapy-induced peripheral neuropathy, and again, the health economical issue are very important. Also in this patient, there are more resources and more money and health staff to treat cancer, but less to treat pain or other symptoms in this patient. My message is make the pain visible, and when it's visible, all of us will treat it better. Thank you very much. I'll be happy to answer to the questions.